right, thanks, guys. So, was there anything on that list we didn't talk about? So, hopefully, just that we were talking about all these structures, you all feel good about that, and you're ready for a lecture quiz, which means that, you know, you're half of the way ready for that take-home open book test. Let's make this test full really count to boost you, right? Be ready for that before you open it. Again, make sure that you have it completed by Monday morning. Fair enough? Before you come in here for the exam, because I will go over the questions for you all at that time. Okay, so we're going to start with this. Well, we started with the male, but now we're going to do the female reproductive. Look at the female reproductive system, which we, you know, are also going to need to know the anatomy. You'll have that lab. We could do that lab Wednesday. Do y'all want to, just so you don't have to think about it after that? I mean, let's do it, because we'll be talking about these structures anyway. So you won't have a lecture quiz. You just will have the lab labeling. So make sure that you're ready for that Wednesday morning. Let's get that out of your way. Okay, so I had said that when we came here for the exam, we could do that lab then. But let's just get this lab now. It might look a little crazy to you right here, this mid-cycle section. It looked like there's a lot of structures. But just as we did with the male reproductive system, we're going to talk about all these structures. So get this idea in your head about what these structures are. I have 3D models of these structures. I think it's a great thing to look at. You know, not just one picture in your textbook. That's just not an acceptable way to study the anatomy. And even when you have 3D structures, or even cadaver studies that you look at, or you know, the visible body, or whatever you're looking at, are any two individuals exactly alike? No. So you really do have to have a pretty good command, if you will, of where these structures should be, right? And what is considered to be normal anatomy. So let's go ahead. We're going to start talking about most of these. This chapter does a little bit repeat of what was in the male system as far as sex differentiation and just gestational development, embryonic development. But we just had that, so that it does that so that the chapter itself could kind of stand alone. But we do understand that females are really formed. I told you I shouldn't have used the word by default, but in a way, the organism becomes a female if there's not an SRY gene present, right? Meaning there's not a Y chromosome, because females have 11, their 23rd pair of chromosomes. Two X's, right? So there is no Y. That means there is no SRY region, the sex region of the Y, and then the organism becomes a female. I think I'd already talked to you about like analogous tissues and structures. So the tissues that have the potential to become either the penis or the clitoris, you know, they're going to be acted upon by these hormones. The labial folds will become scrotal sacs. So I talked about all of this, right? So they repeat this a little bit. We know that the gonads in males are testes, but the gonads in females are ovaries, and these are the primary sex organs. I think if we remember, you guys remember that the ovaries are going to be targeted by FSH and LH. Again, where are those two from? Pituitary. They're going to be released from the pituitary. Follicle stimulating hormones were to be released, sent to the ovary to target a follicle so that an egg can mature. Okay? And we said LH will be sent through the bloodstream and will target the follicle about mid-cycle so that ovulation will occur. And ovulation is actually an event. It is an event where the follicle ruptures, and as it ruptures, it actually spills out this developing egg. And so this event is referred to as ovulation, and it's because of luteinizing hormone, LH. Will you all have that on the reproductive test, do you think, what FSH does and LH? Absolutely. And will you see it again on the final exam? I'm just going to tell you you will. So please, I hope you know these by now. Okay. So we have also the internal genitalia, which is the duct work. And it really is duct work when you think about it. It consists of uterine tubes that people call fallopian tubes. I think most of you all refer to these tubes that connect those ovaries to the uterus as fallopian tubes. But anyway, they're calling them this. The uterus is really a muscular organ, muscular sac organ, where the development, the gestation is going to occur. So I think most people know that too. And the vagina is actually referred to as a birth canal. It's also sometimes just referred to as the birth canal. So the external genitalia we think about is going to be the clitoris, the labia, minor and major. You know, this is just Latin, labia minor, which is so much prettier, isn't it, Latin, than whatever. But the labia minor, the labia major. And this makes up this perineum that we're going to take a look at in just a second. And then, of course, there are these accessory glands beneath the skin for lubrication, because that's also a very important part of the female anatomy. If we looked, and I do have some 3D models of this. This is removed. These structures are internal, so they've been removed, and then coronal sections have been made on this right side so that you can actually see into the lumen of the uterine tube, the fallopian tube. So we'll look at bigger pictures. Well, let's just go ahead and look at a bigger picture right now of the uterus itself. Obviously, all these tissues have to have blood supply. So the blood supply has to be maintained, and then venous return has to be maintained. So if you look at the rugae of the vagina here, or the birth canal, you can see this is the vagina or birth canal. The cervix of the uterus is actually the neck of the uterus that's extending into the vagina. So that's what's referred to as, because we know cervix means what? Cervical means what? Neck. That's what it means. In this particular case, we're talking about the neck of the uterus that extends down into the vagina. There is an opening here that's usually shut. It's usually filled with mucus. That mucus is not a bad thing, it's a good thing, isn't it? And it's very viscous, so it is usually shut to anything that's in the vagina, because obviously there's normal flora and the vagina, protecting the female, protecting the female from potential pathogens. So we don't really want to always have an open highway here into the uterus, because this open highway would extend to the left and to the right to open up actually into the peritoneal cavity, into the abdominal pelvic cavity. You see that, right? So this is usually shut. If everything's normal with a mucus plug, if everything is normal and healthy, then what ends up happening is there's really just a little bit of window of time each month that this thins out a little bit, just enough to form a slither of an opening so that sperm can actually enter into this area. Because sperm, are going to be deposited here, and then they've got a long way. Think about how far that is to go. They have a long way to go. And normally, one ovary a month will be targeted for a follicle to develop. So some sperm, they're going to enter, and they're going to go the wrong direction. So when they go the wrong direction, they're doomed. They're never going to make it, are they? But then some will actually go to the direction of the ovary that has the egg that's maturing. If I'm saying anything that's crazy, or if y'all have any questions, please ask them, okay? So anyway, you will see from this just illustration that this is a muscular sac, isn't it? And it really is a muscular sac. It's, when we think about the layers of the uterus, I want you all to know that the inner layer is called the endometrium. This muscular layer is the myometrium. You're going to have these on your slides in a second, but I just think you should understand this. And then the outer is the perimetrium. So these are distinct tissue layers of the uterus, but essentially the uterus is a muscular sac that has the ability to support the gestation and stretch and grow, doesn't it? But it is a muscular sac. So if you've never felt, even externally, felt somebody's uterus contracting or had a uterus that's contracting of your own, it's a whole new experience, right? So, I mean, it really works and does its job. So anyway, this endometrial layer changes throughout a monthly cycle. And it actually, you can, I know I've used a lot of farming analogies, but it's because I grew up on a farm. You know, if a farmer was going to try to grow something, do they just go out to a uncultivated, barren kind of field and throw their seeds out? Do they do that? What would a farmer do? Well, they test that, but they sometimes are going to put a layer of topsoil down. They're going to turn off the earth, aren't they? Turn off the earth, put a layer, maybe it's topsoil down, put some fertilizer on it, thing, right? Then they're going to actually, it's not, the seeds are not just going to be thrown on the top, are they? They're going to be put in to the earth, aren't they? Depending on which. So in a 28, and we talk about it as 28 days. I know it's different, but that's an average 28-day cycle if somebody's not doing anything to artificially change their cycles. And the average woman is going to have a 28-day cycle. What's going to happen during that cycle is that this endometrial layer, that's all going to happen to this endometrial layer. It's going to build up, just like adding a layer of topsoil. And for that, is it going to take good blood supply? Is it going to take good nutrition? Is it going to take everything working like it's supposed to? It is. And that endometrial layer is going to thicken. And it's going to become incredibly vascular and really nourished. Because if an egg gets released here at the ovary, and if a sperm fertilizes that egg, and y'all look out here at the ovary, if that gets fertilized, and it's usually right at the mouth of a fallopian tube that have these little finger-like projections that are trying to scoop up the egg after it's released. See the little egg release? So if the sperm gets here and fertilizes it, which is usually right around here, it's going to take about 6 days for it to get all the way back to the endometrial topsoil that has been plowed and cultivated and nourished and enriched and thickened. And if that newly developing blastocyst, and y'all were ready for that today, weren't you? You were ready for zygote, blastocyst, embryo, and knowing the date so that it'll be on the test, and fetus, right? But if that blastocyst, 6-day-old blastocyst, gets here, the endometrium is ready. And hopefully it will be caught in the endometrium, and you will actually see on the little film that we see, you guys are going to see it being sucked up underneath the endometrium, and that is actually pulled in by the mother's tissue. So that's called implantation. Now, if implantation doesn't happen, it doesn't mean that fertilization didn't happen, because fertilization is just an event too. It's an event of where the sperm actually gets into the egg. So the zygote blastocyst could be going, but it could just be lost and not implanted. One of the ways IUDs work, intrauterine devices work, is by constantly kind of keeping an irritated and thin endometrium. It's going to be much harder for there to be implantation. There are also hormones that are being secreted that should be preventing the fertilization, but it is suspected that many times that actually is actually happening. So, but it's just not allowed to implant because of the IUD. So it's just lost. It's actually thought that as many as 1/4 or more, you'll hear different numbers of actual fertilized blastocysts never implant. This is sounding like it's hard to get pregnant, is it? No. You know, the numbers now in our country are about 1 in 6 will experience some difficulties with fertilization, but the other 5 out of the 6 can usually get pregnant unless they want to. I want you all to keep this in mind just so you understand, even though we look at these, what has to happen, what has to be just right, and you think, God, is no wonder anybody gets pregnant? No, it's easy. So So anyway, just so you know, you're realizing that. Any questions for me so far? All right. If implantation doesn't happen, then what is going to then happen is that newly cultivated topsoil endometrium, if you will, endometrium, that is going to be shed. So it really is the endometrial, it's an actual special area in the endometrium called the stratum functionalis, but I don't care that you know that. It's just that top endometrial layer will be shed, and that's what people call their menstrual flow, right? So that is what is being lost during a menstrual cycle, is that last month's topsoil layer. Don't call it a topsoil layer, but you know what I'm saying. Now, this tissue, this special tissue that's called endometrial tissue, sometimes it's not just found in this inner layer of the uterus. Sometimes this tissue can actually migrate. I think there is definitely a familial component to this. Sometimes women have a problem because this endometrial tissue can sometimes migrate out and into the pelvic abdominal area. It can actually even migrate to the diaphragm, which is a long way away, or to muscle. It can migrate to the lungs. It can go through the bloodstream to other areas, but it's still endometrial tissue. So let me ask you this. During the monthly cycles of hormones that I told you the endometrial layer tissues are building, would those tissues still be influenced, even if they're not in the right place? And would the shedding of all of that happen still, even if they're not in the right place and there's nowhere for it to go? Yes. Does anybody know what that condition is called? Endometriosis. So endometriosis is actually a condition where the endometrial lining, the tissues of the endometrium, have migrated outside of the uterus. You know, that doesn't even sound like it would be a good thing, does it? Now, some people get told that they're going to have difficulty conceiving if they have that. Do you know how many babies should be walking around with the middle name endometriosis? A lot. A lot. Because only a rare few will have real troubles. But when you tell someone as a medical professional you have endometriosis, this can lead to potential fertility issues. Guess what they hear? I can't get pregnant. That's what they hear, that I can't get pregnant, so I don't need to use birth control. And that's what they tell their significant other or others. And so guess what happens? Little endometriosis comes. It should be middle name, little endometriosis. Sorry, I'm just saying. When people get told things, sometimes they're being told exactly what I just said. You may have difficulty conceiving, but that's not what they hear. I can't tell you how many women get told they have a tilted uterus. Would anybody share with me that you've been told that? And they get told, oh, you may have more difficulty conceiving. Absolutely a myth. A myth. That's a myth.
PCOS too.
And they tell you the same thing. They tell you the same thing. So please understand that the PCOS and endometriosis are things that, females will have to deal with and should be proactive about. But as long as they're not the extreme cases, there should not be too much difficulty. And I'm saying this from, I had very good friends that were high-risk OBGYNs. And this is just so, we know this, but people hear different. And I'm not please don't think I'm criticizing women for hearing it that way. Because if you didn't have any medical background and someone said that to you, can you see how they would interpret it that way? I absolutely can see that, how they would interpret it that way. Yes, did you have a question? Somebody?
There's this girl I know, she had ovarian cancer and endometriosis, and they told her that she couldn't have a baby, and they were going to have to take out her reproductive things. Anyway, so they gave her a year and said, if you don't get pregnant this time, you just can't. Anyway, so she had multiple miscarriages, and she finally had her baby.
So ovarian cancer has a really high mortality rate. It's a horrific diagnosis because of the mortality rate for ovarian cancer. I think a lot of times there's also misinterpretation about a female female reproductive system cancers. Ovarian cancer, nobody's going to wait for you. They're going to remove it. They can't wait. And now, what they might do is leave the other ovary, but they usually don't even do that either. And then you would have no choice. But there are a lot of other types of cancers. There's cervical cancer, isn't there? Uterine cancer. There's cancers of the fallopian tubes. And then, truly, there's something called ovarian cancer, which has a significant mortality rate. And they don't wait on you. They remove them. They won't let you have a baby during that time. Estrogen to cancer is like you throwing gasoline on your leaves when you're burning your leaves. Who of you know people who throw gasoline on burning leaves? I know some people. It's not very smart because what? it's just going to burst, isn't it? Estrogen is the same way with most cancers. And so usually they're not going to leave either ovary because they can't. If it's truly ovarian cancer. But there are a lot of other kinds of cancers too that can happen. Pregnancies, typically, again, this is why when somebody does have cancer like melanoma, which is obviously not related to the reproductive organs, but if they have that while they're pregnant, does it exacerbate the speed of the cancer? And is that one of the cancers that can cross to the fetus? Yes. But you'll have people who get that diagnosis during pregnancies and decide to continue on with pregnancies. But we got a little bit off track. Let's go back to normal. Okay, let's go back to some normal situations. Important to understand the differences, though, in these structures and the differences in the anatomy and physiology. This is actually, I think, a good picture to look at all this stuff. So anyway, so we've talked about a few things here. And again, you can see these terms and you can see the different layers of the endometrium. You kind of know now what endometriosis is. What happens, and this is a closer picture for you all to see that there's certainly blood supply, arteries to these, and venous return to these tissues. So what happens while this endometrial layer is building up is that these arteries are dilated, they're bringing blood, they're bringing nutrients to the site, tissues are building, mitosis is happening, this is all good stuff. But if no implantation occurs and no hormone cycle occurs, and we're going to talk about the hormone cycle in just a second, then these arteries start to constrict. And so this constricting of the arteries is what's going to end up causing the death of that innermost layer of endometrium, is why that layer is shed, and what you call menstrual flow, right? Should it be actually blood from the peripheral blood though? Should menstrual flow, even though it looks like, blood, is it really blood from the peripheral vessels? No. So if somebody tells you that you're anemic, ladies, or any lady get told that she's anemic because of her heavy menstrual flow, then that's not normal at all, because nobody should be. That would be called hemorrhaging, right? So some women have heavy menstrual flows because they're endometrial, they got a lot of topsoil, and some have less, but it should never be blood from your peripheral blood. It should never affect your hematocrit. If it is affecting your hematocrit, something needs to happen to correct that. Is everybody good with that? All right.
I'm dying.
You're dying?
I'm dying.
Yeah, so I know a lot of women who say, oh, well, I've just been told I'm anemic because I have such heavy menstrual cycles. They should maybe get a new doctor or figure out, maybe that's not really what the doctor said, but you know what I mean, he or she said, but it should not be from peripheral blood. Okay, so you can see these bodies here. So the vagina is also referred to as the birth canal, isn't it? So it's this sensible muscular tube And after puberty, we said this is one of the few areas that with puberty, the onset of those hormones, FSH and LH and estrogen and progesterone release, the tissues that are lining the vagina change, don't they? They undergo metaplasia. And typically when we hear that term metaplasia, which means a change in the function of a tissue, it goes from functioning one way to changing its function. When we usually hear the term metaplasia, we usually are very unhappy because it's usually means something that's potentially a bad situation. But there are a few places where it's normal to happen during development. And this is the lining of the vagina, this is a normal thing to happen with puberty. It usually starts to happen a couple years, even a few years, 5, 8 years old, before any menstrual cycles happen. But these tissues start to change. They change from simple, which we said is single layer, cuboidal epithelial, to stratified epithelial, right? Because prior to puberty, the vagina is not a receptacle for, should not have anything in it, you know? So it's not a receptacle for semen, and it certainly should not be a birth canal. So, but with puberty and the first menstrual cycle, this, you know by then, that the vagina has actually changed its tissue function and it is distensible and is a muscular tube and can receive semen and can provide an outlet for the fetus, right? So it can do all that, it changes. There's many bacteria that actually are present as part of normal flora. The predominant one is one called Lactobacillus. This Lactobacillus acidophilus, it should be the predominant bacteria in the vagina, and it keeps the vaginal secretion slightly acidic. Now, please don't think when I say slightly acidic, you're thinking about like hydrochloric acid. It's not like that. It's just enough slightly acidic that it protects the female, even if she's introduced to potential pathogens, as long as they're in low numbers. Now, if they're in high numbers, or if her immune system's not strong enough, she still won't be able to fight it, right? But as long as there's not a good inoculating dose or an infectious dose happening, then these vaginal secretions are very, very protective for the female. Almost all women carry at some time yeast and many bacteria, yeast, even there's normal protozoa. But anyway, you don't want the balance to be off. Many of you all have heard of bacterial vaginosis, haven't you? Many of you have heard of yeast infections, right? All people, not just women, all people have yeast on their skin, and women can carry periodically, sort of transient, can have yeast in the vagina. But it should not be enough of it that it's causing any problem. It's part of your normal flora. But if something happens to your bacteria, like maybe you've been taking an antibiotic, which don't affect yeast, do they? But they reduce your bacteria counts, now the yeast are there, and they're going to have a party, right? So maybe you've heard of candidiasis, if you haven't. This is because this yeast is called Candida albicans that causes yeast infections in women, especially women who have been on antibiotics. So some women are very sensitive to this. If anything upsets their normal flora, their bacteria, then yeast just go crazy. And some women will never have yeast infections. So, okay. But in the same respect, there's something called bacterial. And by the way, are yeast infections sexually transmitted? No. Some women can have real issues with something called bacterial vaginosis. Bacterial vaginosis, again, is not considered sexually transmitted. Although women who have BV, they refer to it as BV, bacterial vaginosis, BV, are usually more prone to continuing to keep it. And again, you know what this is a problem from? It's a problem because the woman's normal flora are out of balance. So their normal microbial flora are out of balance. BV is usually caused from a microbe that every woman has in her vagina. But if you care to know, I don't think I asked you about it. It's called Gardnerella vaginalis. And it can just take over. It can actually, it can just take over, and then it's sort of the like lactobacillus or whatever is just not doing the job it needs to do. This can cause discomfort, just like yeast can. Many of you know what yeast signs and symptoms are of yeast. It's going to be a lot of discharge. Usually, it's considered to be kind of creamy. It can cause these tissues to become itchy and painful and burning, right? So that's yeast. The BV can cause a sort of a purulent discharge that ends up being malodorous. So it's said to be kind of fishy. So vaginal secretion should not be fishy. Okay, that would be an unhealthy situation. So anyway, and it's also called a frothy discharge, whatever. So both of these are very easy to see just from a drop of vaginal secretion on a wet mouth prep. Looking under the microscope, we've got your diagnosis, right? I don't know what else. Oh, and then there are some things that are sexually transmitted. The most common protozoal sexually transmitted organism, protozoal, which is very different from bacteria, very different from yeast. And this is sexually transmitted. Men are usually asymptomatic. Women are not asymptomatic. People call it a trick infection. It's because this protozoa is called is Trichomonas vaginalis. Trichomonas vaginalis is the name of this protozoa. People call it a trick infection, and that does need the woman to be treated with an antiprotozoal, and also a partner. Partners should be treated at the same time because they're usually asymptomatic. This also causes a malodorous, fishy discharge. Fishy smelling discharge. Okay, any questions from me? The most and I'll go ahead and do sexually transmitted since we're sort of talking about. So that's sexually transmitted, and you know everybody involved needs treatment, even though most would be asymptomatic. The most common bacterial sexually transmitted disease, what is it? Who's read the insights? What's the most common bacterial sexually transmitted disease? It's chlamydia. It's chlamydia trachomatis. And most women are also asymptomatic of this, and men. So this particular bacterial infection, if left untreated, for some women will cause enough inflammatory disease that this can interfere with reproduction, because the inflammation can lead to scarring. What can happen with chlamydia is keeping this without any overt symptoms can still lead to inflammatory processes where you have blockages of these tubes that end up becoming scarred. Again, this is why once sexual activity begins, which is normal, people should have routine screenings. You had a question?
So what is chlamydia, right?
Trachomatis. Chlamydia trachomatis. That's the most common bacterial. Some other bacteria that we know of, what are they that can cause that can be sexually transferred? And that you want to make sure you. The thing about bacterial ones, you're kind of, you can treat those and cure them, can't you? Right? So what's another one? Bacterial. Gonorrhea. So Neisseria gonorrhea is another one. That's right. And so, then when we think about viruses, what's the most common viral transmitted disease? Sexually transmitted disease. Can we treat viruses? Can we treat viruses? Yeah, you can kind of treat signs and symptoms, but you can't really get rid of these. But anyway, so you have them, and you kind of have them. What's the most common viral? Everyone thinks that, but it is actually it's well known that actually human papillomaviruses, human HPV, human papillomaviruses are more common. And actually, people who've never had papillomaviruses lead to to warts. So most people, though, have never had a wart, never had a wart. Internally, externally, no warts. And if you really look at the antibodies, can we make antibodies unless we've been exposed to something foreign? We can't, right? But when you look at antibodies, the numbers are kind of staggering of how many people have been exposed to HPV. Now, what do we have for HPV?
Sure.
We have immunizations, right? So it is highly recommended. It's just so highly recommended that in starting middle school age, that you get males and females get the series of immunizations for HPV. Because here's what we know about HPV: there are a few strains of that actually lead to cervical cancer. So if you've ever known anybody who had cervical dysplasia or cervical cancer, whatever, it was because of HPV. Now, this is very, very common. It is so common that, and by the way, women aren't the only ones that can have repercussions of being exposed to this virus. We usually think about warts as being benign little tumors. I want you all to realize that, because all of you've seen warts, haven't you, on somebody's hands or feet or whatever, or other places. So anyway, but warts are considered to be benign tumors that are going to go away after time. Usually a couple of years, they're going to be gone. So, but it doesn't mean you still then have the virus, and the virus can be there and lead to mutational changes. There are a few strains that lead to cervical cancer, penile cancer, so some men have penile cancer. And we think that a lot of the oral neck cancers now are HPV originated. Oral and neck cancer. So the good news is that we have this immunization that we know protects people from this. So everybody's heard of it, right? And hopefully all of you will have had it, that immunization. Even if someone, in case somebody asked you this, even if someone has had a documented case of HPV and they get told that they're HPV positive, they should still go through the series of immunizations. Why? Why would that be? Can anybody think of why that would be? Yeah, because just because you have had it and you've got a positive thing, doesn't mean you've been exposed to the ones that can potentially cause mutational changes leading to cancer. Still get your series, and everybody should have that. And now the Centers for Disease Control are really recommending it to males and females before middle school. Okay, so that's what that's going to do. Well, that's going to reduce the numbers of cervical cancers, and which, by the way, cervical cancer still is one of the leading causes of cancer in women in this country. It's going to take those away, and penile and oral and throat cancers. So let's get those immunizations. Is anybody in here opposed to immunizations? Would you tell if you were? I mean, you can. It's fine. Everybody has a right to oppose. But anyway. Okay, so, and then herpes. Most people have been exposed to herpes simplex. There's actually human herpes virus 1 and 2. They used to call it, 1 was above the waist, 2 was below the waist, but now it's interchangeable, so they don't even screen them anymore to distinguish between the two. Most of us, at least to one type or another, have antibodies. Especially to the cold sore viruses. I told in my micro class that I told somebody one day that the cold sores are herpes simplex. And you can transfer those to other areas of your own body and self-inoculate, or you can transfer to others because it's just shedding virus of this. And I said it's herpes simplex virus. The husband called. I said, you told my wife she has herpes. I was like, when did I say that? It took me a minute. But anyway, then I was like, yeah, she has cold sores. She does have herpes. And so, anyway, that's what that is. And that's, again, you can't get rid of those because they're going to be sometimes dormant forever after the initial outbreaks. Some people have recurrences of the outbreaks, but you can do antivirals and try to control those, right? Because usually they're going to be dormant unless they are active. Any questions about any others? Now, obviously, we know we're humans and we share a microbial world, and so there are other things like HIV, human immunodeficiency virus, that we've already talked about in it. So any kinds of, I mean, even cold viruses can be sexually transmitted. You get what I'm saying? So there should be zero stigma associated with sexually transmitted diseases. Zero stigma. If there is a stigma, it's what's leading to people suffering, and also them being spread. That's also leading to that. So if we could just, in a perfect world, get rid of that stigma, then we would have much less disease. Okay, so this is good right here. All right. Now, when we think about the vulva, this is going to include, we talk about the mons pubis, is that mound of fat that's over the pubic symphysis, and we said the pubic regions of the oscocce meet, and there's a fibrocartilage little pad between them, right? So we know about that. We know about these are referred to as the lips of the female genitalia, the major and the minor. The minor are hairless, the major or the outermost ones with hair. The clitoris we know is the erotic sensory organ. And then we have these glands that are going to end up, the Bartholin's glands, vestibular glands, that are going to actually provide lubrication. So we saw the perineum when we looked at the male, didn't we? And we saw that this sort of area, but what I want to do with this picture is to show you a couple of things, especially with the skin and some of the, obviously, nerve supply, blood supply, and all that's been removed, but just to show you some musculature. It's some of the glands that are really, you should see this guy. Okay. Well, everybody's got a job, that's fine. But what I also want to is to sort of give you this perspective too. You've got the urethral orifice, which is the urethral opening, and then just below that is the vaginal orifice, right? Because we had talked about a female's reproductive system is completely separate from the urinary system, right? But they're so close together, and the walls can be so thin that sometimes signs and symptoms from one or the other can be really misleading and confusing. And probably nobody in here would admit it, but maybe some of you have actually gone thinking, I have a urinary tract infection. They don't need to do, because your mood gets a little ruddy, they don't need to do a pelvic exam. I know it's a urinary tract infection. All you need is a urine sample, right? Or whatever. But to be honest with you, because of the female anatomy, anytime a woman has lower pelvic pain, there should be a pelvic exam. Sorry, ladies. That's the way it should be. And you should try to explain that to your patients too, when they're very anxious and nervous about having had this done, when they're convinced that they just have a yeast infection or they just have a urinary tract infection, and just give me my medicine so I can go, right? But it is important to kind of not think that way. I wanted to also show you this because of something called when we get to the birthing process, the vagina is a distensible muscular tube, so it allows for the fetus to exit. And this tissue has an amazing ability to stretch, if you will, and so again, as long as things happen at a time sequence that you like. But have you ever heard of an episiotomy? Has anybody ever heard of an episiotomy? Is Janet the only one that's heard of an episiotomy? Okay.
Don't forget it.
And see, she says that, and I've had a lot, and I didn't forget. You usually don't feel them, and then as long as somebody is, then you do feel the ring of fire. But that's just the that's the ring of fire, because this tissue is having to expand to allow the fetus to exit. But with an, and you should know what an episiotomy is. They are trying to get away from it because the fact is, if you think about this, how thick skin is, and y'all, not that I'm associating this with rat tissue, but you all were cutting your rats open the other day, and you saw how thin the skin and the muscle and the fascia right beneath it was. Did you see that? And then what happens is there's muscle beneath. So with an episiotomy though, and this is going to happen with dystocia, and you should know the term dystocia. Dystocia means difficult labor, right? So difficult, there can be different reasons for difficult labor. Sometimes the head is large, sometimes the shoulders are bigger than the head, sometimes the position, it can be breached, and that's going to lead to dystocia. So, so guys, what's the normal presentation of a fetus? What's a normal presentation? At first what? Face down. And if there's anything but head first face down, then this is considered a breach. I helped one of my friends Cindy's little delivery of Michael, and he was sunny side up, so he was face up and his hand was first. His little hand was the first thing that we saw. But his face was up, so you sometimes have to get in different positions. So she delivered like on her hands and knees in that position. But anything that's not head first face down is considered breach and is considered a little bit more difficult. It can be more difficult, right? But I want to talk to you about episiotomies because they sometimes have to get done, or they do still get done. But it's really, it means that when there's difficulty, sometimes this tissue tears. And that tearing sounds like that would be a bad thing. But actually, when you tear, it's very natural here for these tissues to be able to do this during this part of delivery. And when they tear, it can be a little bit ragged, but it's very superficial. When there's tearing, there's nothing of these muscles, nerve, blood supply being so affected. But with an episiotomy, and this is why they're trying to stop doing them as much, because most people didn't know what they were doing, or it was difficult because there was crowning happen. So you've got this egg that's coming out. So there's pressure on these tissues, and you're taking a blade and you're trying to cut. You're cutting, and you're cutting down into the side of the anus. And if it's a double episiotomy, they're doing the other side too. And this is allowing for the head and just helping with this difficult labor. But what can happen with them, and you can imagine that this can happen, you can't see. So whatever your blade might hit is going to be something else, accessory structure you have to repair. So there are a lot of people trying to get away from people doing episiotomies. And you can see why that would be. Because though tearing can be kind of ragged, it is typically very, very superficial structures. That makes sense? Now, anybody who hasn't had a child is deciding to never have one. Look, that's not what should be happening. This is incredibly natural. Not everybody tears, by the way. Not everybody tears. So that doesn't always happen. But this is why birthing coaches and whatever, they know that, and you can even assist this yourself, they know that during that whole crowning process, if there's this kind of help with the tissues there, it can help to prevent the tearing. Any questions for me about that? So that's an episiotomy. That word dystocia, y'all know, means difficult labor. The head should be, after the head's delivered, should be easy breezy. After that, the shoulders should not be bigger than the head. If the shoulders are bigger than the head, then that can be a problem. Delivering those shoulders, you can actually break a lot of babies are born with broken collarbones, but that's not the issue. The issue is that there can be permanent nerve damage done. If somebody doesn't help you with those shoulders and know what they're doing when those shoulders need delivering, it can cause permanent nerve damage to that area that can affect the arm, lead to paralysis, can lead to problems after that. Okay, so the breasts are going to obviously, when we think about breast, what we need to realize is that breast is usually just fatty tissue, unless you're lactating. If you're lactating, which means what? You're producing milk. Then there's mammary tissue that is going to be enhanced, but breast are fat. So, and this is actually, again, based on the hormones that are being that are being released. But anyway, I think most people know that what the nipple is compared to the areolar region, the colored region around. And that when you look at the anatomy of a lactating breast, you can see the mammary tissue, the glandular tissue is very much enhanced. And as prolactin is being secreted in a very cyclic kind of way, then milk is going to fill the breast and then eject it from the breast. What causes the ejection of milk? Oxytocin. Exactly. Breast cancer, these numbers are still pretty valid. 1 in 8 women. We know it's higher in certain ethnic groups. I don't like to talk about racial groups because there's one race, Homo sapiens, Oogenesis, but in certain ethnic populations, in certain groups, it is higher. It's certainly higher in darker toned women than others. There's certain risk factors like smoking, obesity, those types of things are risk factors. Heredity, which I just meant about the cultural ethnic type situation. So those can lead to, I want you to pay very close attention to this. 70% have no risk factors. So ladies, that means starting at puberty, what should you do monthly? Breast exams. You need to do them at the same time each month, because if you do them different times of that 28-day cycle, ladies, we all know our breast changes throughout that cycle, doesn't it? The breast change, so you want to do them kind of at the same time to account for that change. And then if you feel any difference or any sort of suspicion value, then you should give a check. But anyway, so that. Now puberty is considered to be, you know, this is saying like 8, 9, 10, but that doesn't necessarily mean that menstrual cycles have started yet. Menarche is going to usually be around the age of 12 on average. I know some of you were probably later than that, so you might have been a little earlier. But it's loud in here today. It's loud. Anyway, so these are just some terms you should know. So thelarchy is going to be development of breast. Pubarchy is going to be these secondary sexual characteristics are starting. So breast development, breast buds, and then, you know, all of a sudden breast. And then you have pubic axillary hair. Sebaceous glands are going to be more active. We all know that at puberty our oil glands kick in, don't they? And then those apocrine sweat glands are going to also be developing. Those are sudoriferous glands, if you remember. And then these hormones are going to be secreted in a cyclic kind of fashion. I do want you to know, again, we already mentioned that a major difference in males and females is that males go through a type of climacteric menopause, but they are always fertile, aren't they? They remain fertile unless something happens to them. They remain fertile throughout their lives, where females will not. So after menopause, there's going to be this cessation of the menstrual cycle, but also there's not going to be eggs formed. In women, it's not about the quantity, it's about the quality, right? So women have, I mean, it sounds like they have plenty, you think about hundreds of thousands of follicles, primordial follicles. But again, in women, it's not so much about that quantity, it's about the quality of what's going to happen. And another major difference is we said that women are born, females are born with all of the primordial eggs they'll ever have. So this is something to definitely think about when you think about little girls and what they're exposed to even prior to puberty. Could it affect their primordial eggs? If there's a young girl and she's had to undergo radiation or chemo or has been exposed to horrific diets or has whatever, could it be affecting primordial eggs? Where we know males aren't even producing sperm until puberty. So this is a major difference to kind of consider. But truly, we are guardians of our genetics and need to kind of understand that. And things could be affecting these eggs. After menopause, because of the decline in estrogen and some other hormones, then we know these are some of the things that can actually happen. Skin becoming thinner, bone mass loss, bone mass declining, risk of osteoporosis, we said, cardiovascular disease increase. So these are some of the things. some women are so sensitive to all of these hormone changes near the perimenopausal, this is called the perimenopausal phase, that phase around it and leading into menopause and afterwards, they will do hormone replacement therapy. But is there controversy to that? Yes, you guys have all heard of controversy to hormone replacement therapy. Again, I think it's just making sure that people get what whoever their clinician, their practitioners are, and feel really comfortable with the advice that, you know, and then you just have to go on some of that faith. And as far as like alleviating some signs and symptoms, some of the risks might be worth it, right? And then some women really don't go through too much of this. It's not a big deal, right? Supposedly you can, if you want to think about when somebody might be hitting menopause, is they do think there's a familial inherited relationship to this too. But I think it's also very much based on how many pregnancies you've had. So if you're continuing to be having cycles and pregnant, then it's going to prolong that typically, usually. So anyway, the beginning of an egg, now this whole oogenesis, you know, we talked about spermatogenesis. This is oogenesis. What type of cell division? It only happens in the gonads. What was it called? Meiosis. So we said that in meiosis, you start with a diploid number germ cell that has, you know, a diploid number, 46, like you have. But what's going to happen is after the first division, and there's two new cells, the homologs all separated from each other. So there's two new cells after the first division have a half number of chromosomes. They each only had 23. But then they're going to have to divide because the chromosomes are in duplicate form. So then they have to divide. And so after two division, how many cells? 4. But here's a major difference in oogenesis and spermatogenesis. And that's that only one egg will actually get everything that it needs. Only one egg is only one of the cells is going to get everything that it actually needs. The other cells that support it are sometimes referred to as polar bodies or nurser cells you'll hear about. But that meiosis is happening to get that one cell that we're going to end up calling an egg, half the number of chromosomes, and all the cytoplasmic inclusions that's necessary for the cell to live. When that happens, that cell only is going to live for a few hours. If a sperm doesn't get to that cell, and again, when you hear about this, you think, how does anybody ever get pregnant? That cell is only going to live for a few hours, and if there's not a sperm that meets it, then the cell is going to die. And the little nurture cells, you know, will also be reabsorbed. So that's just not going to happen. But anyway, so when we look at a 28-day cycle, and I want to just hit on this before we finish with this lecture for today. But when we think about a 28-day cycle, and y'all will see this in your book too, you're going to see this like day 1 to day, if you will, 28 here. This menstrual phase is the first part of the cycle. A lot of people think about the menstrual flow as being the end of their cycle. It's not. The first day of menstrual flow is the first day of the cycle. I want to show you these pictures, and they keep showing kind of the same thing, but if you'll notice, they're highlighting different areas of the days. So the first is the menstrual phase, then pre-ovulatory. This ovulation happens mid-cycle usually, not always, but usually it does. And you know, you can't just assume that it's going to have to do that. I know a lot of Catholics who do that and use that as birth control. And well, so we know about Catholic families. But anyway, they're big. So it doesn't always happen this way, but this is typical we think of. And then we think about post-ovulatory phase that includes the luteal and then the premenstrual. Luteal is referring to the corpus luteum, which was the follicle, wasn't it? This follicle, after it ruptures for the ovulation, releasing the egg, now becomes the corpus luteum. So this is referred to as the luteal phase and then the menstrual phase. What I want you to, I'm going to get to it in a second, and you all would have these if you wanted to see them. You're looking at right now during this 28-day cycle what's happening to FSH and what's happening to LH. Is that right? And this is a cycle when it's assumed that no pregnancy, no implantations happening. At ovulation around the 14th day, you're going to have a few hour window where fertilization has to happen. If it does happen, it's going to take it another 6 days to get to the uterus. Are you with me on this? And this is late in the post-ovulatory phase. This is in the luteal phase that this implantation might or might not happen in the uterus. If it does happen, then the ballgame changes here, right? But let's look at what happens if there's no implantation happening. And I'm going to go to this. This is just talking about different stages. But I'm going to go to these two slides because I like this one. It has the FSH and LH. But now this one has estrogen and progesterone, what they're doing during the cycle. And where's estrogen and progesterone both? Where are they both really high? Right here where the endometrium has gotten, remember what I said about laying topsoil down? Do you see how thick the endometrium is? Why do you think it's thickest right here in this post-ovulatory phase? Why do you think that? Because when is the potential fertilized egg getting here? Right here, right? Does this make sense to you? That the endometrium's at its thickest right here? So let me say this. If implantation does happen here, then this endometrium's not going to be sloughed off. It's going to stay. And this progesterone and estrogen levels are going to stay high because what is going to happen with implantation here in the uterus now is that there's going to be a signal sent back to the follicle, to the corpus luteum, and the corpus luteum is going to keep pushing out progesterone. It's going to stay high because you're pregnant at the time. You're pregnant if this happens. It's considered pregnant if implantation happens. Does this make sense? But if it doesn't happen, then the corpus luteum is going to start to involute. These levels are going to start to drop back down. FSH, if we went back to FSH is going back up, targeting another follicle for the next month, but you're going to slough off that. Does that make sense? This is what's happening on a cyclic pattern. If you were taking, or you have implanted something where you are taking oral contraception, what you are doing is maintaining estrogen and progesterone levels high, like your corpus luteum would if you were pregnant. So what that does, if you are doing that, is suppressing FSH so that you're not ovulating again. So what those meds do is actually make your body think it's pregnant so that you are suppressing FSH. No other egg is going to form, and you're going to just keep those levels kind of high. Most of them are based on both estrogen and progesterone. There's obviously a lot of different types of them that are on the market, but the ideal contraception for females now, there's men have condoms and whatnot, but for females is going to be one that's as low a dose as possible of estrogen and progesterone so that you don't have the other side effects that can happen because of them. And at the same time, you're suppressing an egg forming. Yes?
I was going to ask, so the estrogen levels are high, but estrogen not provoke cancer, but it can cause cancer?
No, at high, it can be like a sure.
Like the birth control, the estrogen in it, is it harmful?
Not considered to be. Like I said, they're typically fairly low, and it's a combination. Estrogen, progesterone, they're typically fairly low, no higher than they would be like in an early trimester pregnancy. Now, as someone carries a pregnancy through a gestation, estrogen levels can increase by 30 times. That's getting way up there, isn't it? So it can increase during that pregnancy, but what contraceptions, female contraceptions, hormone contraceptions are doing are trying to keep it just at this early beginning, low level. You get what I mean? Just enough to suppress FSH. And inhibin does the same thing. So, there are a lot of different kinds of contraception. There's a lot of pros to them, and there's some, some risks to them. We know that some of the risks to them, if women are taking estrogen and progesterone, this does increase your blood volume. There can be risks of, especially people should never take those or have implants or anything if they smoke, should they? They can increase risk of blood clots. They can, yes.
What is prolonged contraception likely to do for somebody sometimes?
I'm sorry.
Like, what is prolonged use of contraception in fertility?
Well, I haven't heard that it really does. Is that really proven?
It's proven.
It's one of the things they say. Yeah, I don't know. I think it would, I can absolutely see if it's an IUD. I can absolutely see how IUDs could. But if it's one of, honestly, you all, since you all are the one, I don't worry about it anymore. But anyway, if you all the ones have to be, I mean, you do worry about it. You should be worried about it because you should be concerned about planning, sort of. The safest really would be the oral, but people don't want to do that anymore because they're busy. I guess their lives are busy and they can't, at the same time every day. You should at the same time, because there's such low doses that you can't skip one and think it's still going to work, and you can't be late on one and think, oh, I missed it yesterday, let me take 2 today. No, that's not how it works. It's really low. Those are considered the safest. But then you have these implants, and you do have, which are going to be different shots, depot. You have the IUDs, that are whatever. And they're going to have a little bit more of a risk, right? So in a perfect world, women would say, well, I get up every morning at sunrise anyway. I'll swallow a pill, and be able to do that because that would be kind of the safest thing that what form of it. But yeah, I don't know the numbers on that. I know they may say that, but I don't really know the numbers on that. I'm wondering though, and this is just theory. This is not like science theory. This is theory like you use outside of the science fact. I'm wondering if it's not because there's some people who don't really realize that just because you're taking contraception doesn't mean you shouldn't be protecting yourself from sexually transmitted diseases. So I think that. I don't know if that whole freedom with your reproductive future has made people a little bit higher incidences of some sexually transmitted diseases that can lead. Now they can lead to some fertility issues. They can, but I have never heard of someone saying that because once you were off of the hormone related things, that should kind of clear and get you back. Actually, what I have heard recently from some of the newest stuff is that women, because we have changed, and it used to be that we would have quite a few gestations, and what oral contraceptions do is make your body think you have a gestational period happening. There are many OBGYNs now that are actually telling females to take the contraception and not have a break and take it for a full 9 months to make your body think that it's going through that gestation, because that's more of what women have had in the past, and they think that I've heard that they've actually considered that to be something that they're looking at as far as ovarian cancer, women who that may actually reduce the numbers of that. So I don't know, but I'm sure that what you read was whatever, but they didn't say why. It might be. Yeah. There's right now, this is good news for you guys. Right now, there have been decades of data being collected. So ladies, if you want the data out there and you should, because this is stuff that does influence you. There has now been decades of data. So it will be really interesting to see, what some of that data is actually suggesting as far as those things go. I'm sorry, I can't really address that or answer that question. Anybody, any other things? I do want to let my males in here understand you have responsibilities for your reproductive futures too. So you're just as responsible for your reproductive futures, right? So it's not just on women. It seems to be, but it shouldn't be. Again, kind of in that perfect world, it wouldn't just be on women, would it? Any questions for me? All right, guys, can I go back to, wait, before y'all put that up, since y'all decided you want this, lab, let's look at this. Let's look at this now. Can we do that for a second? Because we're gonna have this is the only thing you'll have is this lab thing. All right, so obviously, you know, you've got the rectum and the anus here. So this is the orifice for the anus. This is the orifice for the vagina, the orifice opening for the urethra. So, you know, does this look like a bladder? Is this good? Everybody's gonna get that? Bladder, urethra, urethral opening. Inner layer is the minor, labia minor. Outer is the labia major, right? And again, you'll see some Latin variations of those. The clitoris is almost entirely deep, as you'll see here. So you see that, and then females have a prepuce too, right? People refer to that as the clitoral hood, I think. Do they? Did I make that up? I don't think I made that up. So you've got the vagina or the birth canal. Rugae is just referring to the folds and the ability for this to distend. The cervix is this neck portion of the uterus that's extending into this vagina. And then you have the uterus, which we said is this muscular organ. The fallopian tube, which is here called the uterine tube, but you would also know it's called the fallopian tube. And the fimbriae, which are those little structures that are gently encouraging the egg once it's released from the ovary to enter into the fallopian tube. And then you've got the ovary. How do y'all like that picture? Is that good? Is that all good? Any sort of, this is the mons that we talked about, the mons, which is that layer of fat over that bone. So that was fair, right? Would that be fair for lab quiz? All right. Lab quiz. Y'all want to see the 3D structure I have of the female? There's also up here the structure. Rebecca, I have something for you. Casey, I have something for you. These are old ones. Brittany, Macy, which Brittany, there's something later. We'll have it fixed up. Brittany, you see? I'm saying it. Have you been saying?
Yeah. So, I don't need.
No. Did I say Casey?
Yeah.
Oh, I did say Casey, didn't I? Which one? The other one. That's why you always say which one. I thought you meant the one. Three buttons in there. Brittany, how are you? Did y'all have a